Hi guys, I'm going to take the honor and the privilege. First of all, thank you, Susan. To the Emperor of all Mavericks is Dr. Susan Love, and you're going to basically indulge me as I go on a tangent. But it does all come back to the microbiome, and I need some help, and therefore I'm going on a tangent. I read all my slides last night because I need some advice. And if you could bear with me, if you don't mind, so I humbly ask for tolerance as I try to unravel my very cluttered brain. Okay. So the story starts about many years ago, and I do biopsies on patients who basically have residual disease following neoadjuvant therapy. And we basically collected a whole bunch of tumors from patients with residual disease, and we tried to find cancer stem cells. And after a long time, we published this in PNAS. Oh, it moves quite. We found 500 genes, and basically we knocked down all 500 genes, and these were from human biopsies, not from patients. And we found two genes totally undescribed, never described in the literature, and they were called RPL39 and MFL2. Amazingly, these two genes, when we knock them down by, again, sRNA, TensorRNA, they are a profound effect on lung metastases. And because we're PDX models, human mice bearing human cancers, when we knock them down, we can find the pathways that were basically involved by knocking down these two genes, which we believe to be putative cancer stem cell genes, the originating cell of cancer. That's what we thought. The holy grail. You want to think big? Go big. It all comes back to the microbiome, I'm really being honest. And amazingly, these two genes, never described before, converged on one pathway, and it's called the inducible nitric oxide pathway. And this inducible nitric oxide pathway, and why it comes back to the microbiome, it will be clear in a while, it was very strongly correlated. And that was the top pathway. So serendipity, these are a whole list of papers that we publish since then, and in PNS, GNCI, Can Research, the whole 9 yards. So we then established this pathway as being critically important. But we were not the only guys. The NCI were also working on this, and basically, when they looked at their data set, they found that if you had TNBC and if you had high NOS, you had a 20 times more likely to die of cancer. So if your cancer was expressing this gene, this pathway, iNOS, you were 20 times more likely to die of your cancer and TNBC. So amazingly, we then obviously had these patient-derived xenografts. We actually, I went to give a talk in Weill Cornell, and in Cornell there was actually a cardiovascular trial that didn't work for cardiovascular disease. But the guy there, Steve Gross, he had a whole bunch of this drug in his garage. I went, oh hi, and he said, oh, you can have it. So I took it. We first did a PDX experiment. We did it for human PDX models, and it worked beautifully in decreasing cancer growth. And so we then took it into a study. It sounds really easy. It's really hard, by the way, to take a powder in somebody's garage and put it into patients. The FDA didn't quite like it. There are lots of things to do in between, but hey, got it. So we actually, through philanthropy, ran this study, and this was published in Science Translational last year. And this was in TNBC patients. It's a phase 1/2 study. Heavily pretreated patients who received lots of lines of chemotherapy, and the chemotherapy didn't work for them. All right, and we did repeat biopsies. And this was basically what was published in Science Translational. We had a 40%, again, refractory patients in which nothing worked, okay? It blew through all their chemo. We had over 40% response rate, which was stunningly high, much higher than we would expect. What was also really remarkable, and I'm going to show you some gross pictures, this is a patient with locally refractory breast cancer on the right. She came to see me from the county. Basically, she was given anthracyclines, the horrible anthracyclines that should work for everybody. Or if it doesn't work, it won't work. And that is the truth, and we all see this, and it really hurts. And, we've taken care of patients like this, and you kind of you don't usually, give them great prognosis. But amazingly, she went on trial, and she got PCR. She got a pathologic complete response. And now in my lifetime, I rarely see this. In fact, almost never see it when you're blowing through chemo and you give them another regimen for them to get PCR, biopsy probe, and it's almost like nothing. We had a 30% PCR rate for patients in this trial. We had a 30% PCR rate in patients who did not, who basically blew through anthracyclines. Anthracyclines weren't doing anything for them. We had a 30% PCR rate, which is like, wow, very, very exciting. And it's due to this introducible nitric oxide. Now, what is NO? What is nitric oxide? No. Well, it is a substance, it's a gas, which is very high in your in certain foods. And the foods like the nice little sausage I had today wasn't a very good thing. It was very, very high in certain foods, and we don't know very much about it, but we do know it affects the microbiome, and we know it has these profound effects in the microbiome. I'm going to show you a little bit more data, which is not published. Oh, a little bit of more on the same study. We did, it's published. It was published in the middle of last year, I think. Tons of beautiful correlative studies. What this drug does is really quite amazing. Because I was very lazy when I was doing the biopsies, I'm going to be honest, and when we were doing the RNA-seq, I couldn't be bothered to dissect very carefully, so I added a lot of stroma. And what was amazing about this, because I was lazy, truthfully, and microdissection is terribly boring. So basically what we found was that this drug actually influences the microenvironment. It changes the, in non-responders, there's an increase in M2 macrophages. These M2 macrophages are the fatties. They are the ones that cause this immunosuppressive microenvironment. And in the responders, there was an influx of neutrophils, N1 neutrophils. Again, totally this balance, it's not T cells, we didn't see Tregs, we didn't see anything. We saw a difference between M2 macrophages and N1 neutrophils. And this is all published, and you can see very nice little pictures there. Now the next bit, which is basically not published data, if I can get it to work. What? Got it. It's one thing that we found that was really, really amazing is that obesity is a bad thing. We know that. It causes inflammation. And frankly, in obesity, we know that you respond worse to chemotherapy. Studies have been done. In fact, we published maybe 20 years ago now. Again, obesity, the outcomes of obesity, the whole 9 yards. And, you can preach not to eat something really bad, but I live in Texas. If you drive out to rural Texas, there are big, fat, huge food deserts. There are no grocery shops for 20 to 50 miles. Don't preach. There's nothing you can do. I mean, you can tell them not to get a taco, but they're going to eat a taco because they work really, really hard. And when they come back, there's a taco truck and they're going to eat it. And there are no grocery shops. It's very different in California, I get it. But the large swathes of America, rural America, middle America, basically they have no access to good food. And obesity there are parts of Texas where 50%, East Texas, where 50% of the population are morbidly obese. They have no food. There is no fresh food. So anyway, what we found, and because we live in Texas, we actually recruited a whole bunch of patients who are really morbidly obese. This drug caused an 80% decrease in tumor volume in patients who are morbidly obese. It was crazy. It was beyond what we imagined, and it was probably because we altered microbiome. Then we went back and we looked at the tumors in obese versus non-obese patients, and in obese patients, the iNOS levels were sky high. And again, 85%, I'm not very good at doing this, 85% response rate if you were obese, high iNOS expression. So I've got to prove it in mice. So this is old 771. It's really, we basically force-fed, like foie gras, we force-fed the poor mice with a high-fat diet. Actually, it's a hamburger diet, just FYI. And look at the tumors take off. And the lung mets, basically normal, no lung mets, or very few, and then this is studded with lung mets. So a high-fat diet causes this crazy change in tumor volume growth. And obviously I have to show you that I gave the drug, and this is, I'm going to give the ask one. This is better. This is easier representations. It's not very nice. This, I'll show you the right curve. Basically, the normal diet is how much the tumor volume decreased with the drug. And if you're on a high-fat diet, your tumor, as you know, took off. But with the drug, it caused this profound decrease in tumor volume. So, how does it work? This paper is actually at the moment, my PhD student has a oral presentation in AACR this year. It's also it's being reviewed in Cancer Discovery. This is a unusual molecule. It's everywhere, and I know it causes epigenetic changes. We know that somehow it affects the histones, and basically it causes changes in EMT. And we have profound changes when we silence it in just so that you see these are the some 159 cells. We knocked it down with CRISPR, and you can just literally see the cells change from these spindle-like it's going forward. I shouldn't do this. Spindle-like cells into these epithelial cells. So basically, EMT is the phenomenon which we believe causes metastases. So the cells change from cobblestone, which is nice little cobblestones, into spindle-like cells, and those spindle-like cells are able to basically pass through the microvessels into your vessels and then circulate everywhere. So EMT is a process we believe may be responsible for metastases. And this drug reverses it from those spindle-like cells into the cobblestone cells, and then we can kill it off with conventional therapy. And we can see it through knocking it down, and all these Western blots basically just show that EMT, that process of EMT is being reversed by this drug. And always go back to the patient, because I don't know why you don't give Gilead awards to clinicians, but okay, I'll keep quiet. But basically what you can see here, ZEP is basically these are responders. ZEP is the red guy, that's the bad guy, that's the mesenchymal one, the spindle-like cells. It goes down, you no longer see it. E cadherin is a good guy, the epithelial guy, and you can see the green goes up. So in responders, you have a decrease in the red and an increase in the E cadherin. So you have a reversal of EMT. Cancer stem cells, that's marked by ALDH. The marker of cancer stem cells, the so-called mother cell, the originating cell, goes down. In non-responders, you have the reverse. The baddie, the red, goes way up, which these are the mesenchymal cells. And you have basically the E cadherin, which is the good one, but one that responds to chemotherapy usually does not go up. And the stem cells don't go down. So we have this drug, and if you respond, we believe we cause a decrease in EMT and a decrease in cancer stem cells. So we now awarded award last and actually the first patient went on study on January 31st, and it is used this drug with alpelisib, and this is a U01 award, which we have 3 collaborative centers, including the NCI. So any patients who basically have metaplastic breast cancer, which is the most mesenchymal of all, the NCI will be opening this study probably in the middle of this year. All drugs will be provided, all transportation provided, and this is a metaplastic breast cancer. It's the most lethal of all breast cancers. It's probably, it blows through everything. Chemotherapy doesn't do anything, and immunotherapy to date doesn't do anything for most people. So this is I haven't shown you some of the data, but it's truly exciting, and we're really, really excited. But we do all believe it ties back to the microbiome, because this is a drug that is basically, it's your food. Your food's really, really high in nitrates and nitrites, which increase NO, which then I believe does something epigenetically that regulates TGF-beta that causes EMT. Sorry, it's a whole mouthful. I have to prove it. I haven't proven it. I'm really sorry, but that's what it is. So where are we today, and why have we gone back to this study? Well, Dr. Love and I, well, it was Dr. Love's idea, basically, we believe that we don't know what's happening in the breast. We know there are microbacteria, and the microbacteria is frankly all over. You have more microbacteria on you than you have your human genes. And so basically, and it's everywhere, right? Your skin, and now you have the so-called dry organs, the breast, but you definitely have it in your gut, and you have it in your mouth. So the breast, where does the microbiome come from in the breast? Does it come from the gut? Does it come from your baby's mouth? Or does it come from your partner's mouth? Where does it come from? So this is a big fat unknown, but we believe that the microbiota, or your food, it could be the food your partner eats, who knows, right? So this microbiota is completely unknown, but I believe it somehow influences the microbiota, that influences NO, that influences all that, blah, blah, blah. Yet to prove, hopefully, in my lifetime. So basically, move. I don't have to go through a lot of these things. Oops. But you know the systemic local effects of the microbiota. There are lots of things we don't know with the systemic effects. We just don't. We know it's responsible for obesity, it's responsible for cardiovascular disease, it's responsible for cancers, not just locally, like H. pylori, but it's responsible for other cancers that we know nothing about. And basically, it also affects the way in which you respond to treatments, both chemotherapy. So is obesity a consequence of the microbiota as a consequence of why you don't respond to chemotherapy? Or is it just because I didn't dose you right? I don't give you enough drugs because you're obese? I don't think so. Even I try to dose max. I mean, I'm not terribly afraid. Sometimes I am. But I try to do dose to BSA. I try to dose accordingly to your weight. But even then, patients don't respond as well. Why? So the microbiome and cancer, I think the mouth has a lot to do with it. We just don't know. And so there's Fusobacterium in the mouth that's completely different. We know that the bacteria in the mouth can activate these immune pathways like STAT3 and IL-6. And we know response to immunotherapy is totally different. Adoptive T-cell therapy is completely different depending on your microbiota. And even the PD-L1, PD-1, CTL4 immunotherapies are completely altered by the type of microbiota that you have. So we began some of these early studies, and we basically, nothing much. We looked at, we have humanized mice too, so we moved on with these little mice that, that we grow human tumors in, but usually they don't have an immune system. So what we did was we basically gave them a human immune system by doing a little bone marrow transplant on them. So each individual mouse has a bone marrow transplant and has human bone marrow and human tumors growing. And so we want to basically figure out what's happening to the feces and how it may affect tumor growth. And so what we do see is when you have fat and skinny mice, and again, there's cruel things that you do to feed them hamburger every day, but basically when you treat them, the Bacteroides species basically completely changes. Very early data, know nothing about it. So back to the study and why we wanted to start, because the origins of most things is what's happening in the breast, what is the microbiota in the breast, how do we get there, how did we get it, and so we are beginning a study hopefully this year. Where's Teresa? Teresa, we're beginning a study this year. Got it. And
hopefully, yes.
but this is a work in progress. So you tell us what you think needs to be added to this. It's 100 patients. It'll be done in Mexico. We'd love to also open it in Houston, Texas, where we have lots of African Americans. There are lots of demographics that we will actually look at. We'll collect all the ECRFs. We'll have their obviously race, height, BMI, and drugs. What drugs they're on, cardiovascular drugs, etc., how that may actually change it. And basically what the study is very straightforward. And basically is to do lipoaspirates, take the tumor itself, the surrounding normal breast, oral swabs, rectal stool specimens, and basically just analyze by 16S the microbiome. Simple study. Let's figure out where this stuff is coming from and how it's causing inflammation. It's a straightforward study. It's a basic study that basically works on the previous study that basically may hopefully prove that the duct that has the cancer may have a different microbiota around it. And this is, as you know, it was basically how to conduct a lavage. It's actually not so hard. Once you get through that horrible duct, it's not that hard. You just have to find it. I mean, of course, you do wear glasses, but other than that, it's not that difficult. And it will be done in patients undergoing a surgical procedure, so that it will be much easier than that. It'll be easier when they're not like screaming in pain. They're not screaming in pain. It's easy. And so that's basically the study. This is basically, and we also will have the surrounding tissue, where I would love to do. There are tons of ways now that we can do looking at the immune microenvironment. Codex is probably, or phenocycler is probably the top, my favorite at the moment. But there are tons of new ways in which we can look at the tumor microenvironment, because what's happening is whatever the bacteria is somehow switching on an immune cascade. Let's figure out what the immune cascade is. I think it's N2 and N1 ratio. It could be a gazillion other things. There are areas of hypoxia, tons of things that can be going on here. It would be lovely to basically look at the immune complex around the cancer as opposed to other areas. And if we can identify bacteria, how is it causing this inflammation changes that's causing or leading or assisting the cancer growth? So in summary, I believe the microbiome signatures, we know that it's been associated with tumorigenesis, inflammation, cytokine response, chemoresistance, modulation of response. And we know that the nipple aspirate fluid, oral, rectal, around the breast, will be collected for analysis and microbiome signatures. And we want to look at the tumor microenvironment, especially for T cell subsets, MDSCs, M1 versus M2, cytokines, PD-L1, PD-L1 expression. Thank you. Go, Sarah, be nice. I know it's early days.
That was a beautiful talk on the INOS inhibitor and the effects that you have shown with nearly 40% response in the taxane resistant tumors. So this is so the question I had was regarding the increase in INOS in the responders. Can you tell me what the amplitude of that response was? Because I saw maybe a doubling of the expression of INOS in the obese patients.
More than doubling.
More than doubling. But
what
when
would
I
be the
looked at the figure,
Yeah.
it didn't look like that. So, okay. So now, so you have two connections. One is the drug and one is that the INOS expression is going up. In the obese patients, yes? So now the question is, how is it doing it? Do you know the mechanism of action of that drug?
TGF, we know how it works in terms of cancer, how it's pro-tumorigenic. It would be presented in AACR. It probably works through TGF-beta. It modulates TGF-beta, and then through the AKT-PI3 kinase pathway, and then causes cell growth that way. It's a pretty, so through the I-SPY samples. So that's one pathway, how it causes it. But it's also very present in chemo-resistant tumors. Almost all chemo-resistant tumors will have an upregulation of this. So I-SPY samples are being interrogated at the moment, or several hundred of them, in all the different subsets. It's probably going to be uniform, even in HER2s. So that's getting done now. And then Laura Ashman will probably run an I-SPY study with this.
So will you be going into the molecular mechanism, just using cell lines and stuff?
Yes.
Because you can make these cells fat.
Yes, we're trying. So we're using the conditioned media, we're making the cells fat, we're trying to figure it out. It's hard, help me. Somebody take it. It's easy to eat burgers.
Hi, beautiful talk, a lot to learn from it. And I just want to ask you, have you also looked at your inhibitor, when you give this inhibitor, you see tumor inhibition in obese microenvironment? Did you also look at the immune cells and all the immune repertoire around the tumor cells there?
Yeah. So that's where the M2 and M1 and neutrophils come in. And I think that what we're going to find as well is that when you have, ideally, don't know what the origin of the bacteria is, but I bet you somehow it's affecting the microenvironment. You're going to have a different immune environment next to the microbacteria that's promoting all these immune cascades. Who knows? But we actually have the tools now. You can actually visualize. And that's where the very expensive, but I'm quite rich. My institution is quite rich. That's a good thing. Where you can actually see and, you know, it is true. But you can actually visualize. They're very expensive, but you can visualize. That's where I feel the key is. I think, you know, human samples, visualize. This smart PhDs go figure out the mechanism. We can help. We understand it, but we can't. I can't figure it out by myself. I can do the biopsies. I can stick things in things, but I can't figure it.
So the next step would be looking at the microbiome composition and trying to look at the microbes that are actually doing this. And the last comment, I can help you with that.
Yes,
Making
please.
the cells fat.
Can you? Okay.
We do that clearly.
Okay. Fat. You do fat? Okay.
Yes.
Is there any difference in the application of this mechanism like site of metastasis? Since it's obviously very microenvironmentally driven, does it depend on, is cell cycling a necessary aspect for the drug to work?
We haven't seen apart from the brain, we haven't seen a predilection to one or another site. Lung and liver are the most common. These are TNBCs. And maybe lung will respond better. This is a maybe, but don't know. We've had patients who I've had a couple of patients of this. It's a very small study. Obviously, we had 3 PCRs, which is they're alive. But even in the metastatic setting, I've had 2 patients who are alive. It does something weird to the microenvironment. I mean, this is a really small study. So we've had, now it's finished for about 3 years, and there are patients who are still around. So I don't know why. So there are always miracles in life.
Sorry. So I'm actually a triple-negative breast cancer survivor. And it's funny that you bring this up because I'm very interested in it, because right before I got diagnosed, I was doing a keto diet.
Oh, interesting.
So I'm wondering how, because you're saying that you fed the mice, a lot of hamburgers, and I eat a lot of hamburgers. So while you're administering this drug, do you then restrict the hamburgers from them?
Yeah.
Okay, because that's interesting too. Diet's not brought up
Yeah.
a lot in treatment, so to go back to my other advocates and, remind them that they need to talk to their doctors about their diet while they're in treatment, because if they are doing a more high-fat diet, that's delicious and we can eat them while we're in chemo, and that's fine, but be mindful of all of this. So I'm very interested in this.
Let us prove it a little bit more. These are still hypotheses, and obviously we can be very wrong.
Yeah.
We love to prove it.
Yeah. Highly accurate.
We have time for one more. We have our Zoom panelist ready next, so.
Just a quick question, really clarification for my information. You were saying you're collecting little aspirate fluid, but you're demonstrating collection of ducts and lavage. Are you collecting those, or
You're collecting both. We're doing like a lavage.
do you see a difference in the kind of results?
Don't know yet.
Thank you.
Study is not done yet. I think we need to measure maybe metabolomics as well, but we'll figure it out just before the study opens.
Thank you.